Hello, hello. Okay, good morning, everybody. Thank you for coming. I want to welcome you to our program this morning on price transparency. There was some recent news about Medicare charge data that came out, and you probably saw in the newspapers, and showed the vast variations in hospital charges to Medicare patients. And hospitals, as you know, keep two sets of books. There's the charge data and there's the actual charges, bill charges that people pay, which varies tremendously. And so it's really very apropos for our discussion today on price transparency. If you're going to have a price competitive system, you really have to have information. Patients have to have good incentives and purchasers have to have good incentives, but you really need information. And so the whole idea of price transparency is getting better information to purchasers. The problem is that not everybody's in favor of that. Because if you're a hospital with a lot of market power and you can charge different prices to different people, then you don't want everybody to know what your prices are. So today we're very fortunate we have an expert on price transparency to talk to us today, Andréa Caballero. Andréa is the program director for Catalyst for Program Reform, which is an independent nonprofit corporation working on behalf of large purchasers to promote high-value healthcare. Andréa has had over 15 years of experience in the healthcare sector. She's an expert on price transparency. She previously was a vice president for United Group Health on a range of health policy issues at the state and federal level. And Andréa was recently a participant in a Federal Trade Commission discussion on price transparency. So please welcome Andréa.
Good morning, everyone. How's everyone this morning? Thank you, Dr. Feldstein, for that nice introduction. And thanks to UCI and Margaret. I've attended many a conference here at UCI, and I know how much work goes into it, and it's nice to actually be in this small setting in this room. So I wanted to start off, you know how most people say, well, let's, the proverbial icebreaker, how are we going to, start something off? And I will be completely honest, I am not a good joke teller. I don't tell jokes very well, so I just thought I'm just going to let this unfold and have it just be very natural, except kind of came to me this morning on my drive down here. I live in Long Beach, and I have lots of traffic on the 405, and it's not uncommon for me to call my parents from lots of different places. I'm either in an airport or on the freeway or not at a bus station or anything like that, but I'm usually somewhere not at home when I call them. And so I called them this morning, and they live in Wisconsin, 2-hour time difference, and so it was not surprising that I would call them at this time. And of course, my dad usually says, "Here's your mother." He doesn't really want to talk so much about this stuff, but she wanted to know what I was doing, where I was going. So I was telling her what I was coming here this morning to talk about, and I have just finished quite a bit of work on bundled payment for hip and knee replacement. And my mother has had 2 knee replacements and 1 hip replacement. And we've actually had a lot of conversations about her, she's Medicare eligible, we've had quite a few conversations about her services and all of the services that lead up to it, and then post-op, recovery, all of those things. And I was talking to her about the bundled payment side. But at the end of the day, I was telling her all about sort of the price transparency and and usually when Nick Franklin, my former boss, is here, and he saw me through some stages of healthcare reform and state legislative activity where I would talk to either my parents or at dinner parties around medical loss ratios and accountable care organizations, and most, people kind of go dark. But price transparency is one of those issues that my mother really understood. There are a lot of articles about this in Wisconsin, very competitive markets in Wisconsin, and so she's paying a lot of attention. And it's one of those that really just about everyone can relate to on some level. We all have sort of a different perspective probably, but she was very enthusiastic, and whenever I speak on these kinds of topics, I think about how would I explain it to my mom, whether I was lobbying on a certain issue or whether I'm speaking on a policy issue or something like that. It's how could I explain it to her? So she was, she didn't know it, but she was some of my inspiration this morning. And the other thing that as we talk about price transparency is that, again, my former boss, Nick Franklin, I'm not sure if he remembers that he told us this when we were working for him in public affairs, but he would say, if you're not at the table, you're on the menu. And price transparency is one of those issues where, regardless of where you sit as a stakeholder, if you aren't at the table, you're likely to be on the menu, because this issue, the movement, it's moving and it's gone, and there's really no turning back on it. So creates a lot of discomfort for people. I get that. I'm sort of an equal opportunity offender. So I know we have a diverse audience in here, and people might not like everything that I have to say, but I think that's okay. That's what the debate is for. So again, thank you for inviting me, and I really appreciate it. This is an agenda slide, not a big deal, but I wanted to set the stage with some key definitions. We all sort of talk about price transparency slightly differently, and I wanted to at least set the stage with some common terms. The arc of the story today is where we are, where are we going, and what's in our way. And so those are the main topics I'll be talking about. I'll talk about the existing landscape and what we found at Catalyst for Payment Reform, and then I'll also be doing some forecasting about what's on the landscape, what are we going to see in the next couple of years. And I've probably given about 20 speeches on price transparency in some form or another, and you can't have a conversation about price transparency without acknowledging the barriers. So the sort of end of the conversation will talk about barriers that we see to price transparency and achieving true transparency. And then we will, because this is primarily a California crowd, we're going to talk a little bit about what California is doing in transparency. So who are we? Who's CPR? And you might be wondering, why is Catalyst for Payment Reform talking about price transparency? And Paul introduced who we are. We're an independent national nonprofit working on behalf of large employers who purchase healthcare, and we're trying to change how we pay for healthcare in this country. And our members, about 33 members, represent both public and private sector. We have 8 public sector members now, one of them being CalPERS, and these are very large purchasers. Many of these, the other state purchasers are Medicaid programs, and I think you'd be really interested to know how much progress is being made on payment reform in the Medicaid sector. And when CPR was formed, these large employers, not all of them, but sort of the original 10 or 15, if you will, we now have 33, the original ones wanted to set a shared agenda. What could they talk about that could send a consistent message to the marketplace? And I won't go through all of the things on the right side of that agenda there, but one of those things is price transparency. It was somewhat of a short-term goal that I felt we could make progress on, and it's a building block to payment reform. Employers really have a hard time seeing a future high-value healthcare system if we don't have some sort of price transparency and quality of transparency for that matter. So the point of view that I really bring to the table right now is through the lens of the purchaser and by extension the consumer. So when I talk about it, that's you'll hear that bias. But when we get to the barrier section, you'll understand sort of where there are, as purchasers, we're also quite realistic about what can occur. So I just wanted to give a little bit of a definition of price and price transparency. My next slide is a different definition of price. So I want to start with CPR's definition, and this is actually a GAO definition. Like I said, we look through this issue through the lens of a purchaser, and basically price transparency is the availability of information on a specific provider about a specific service or set of services. So the transparency is the availability of it. The price, when I speak about it, and CPR speaks about it, and purchasers speak about it, is what is the out-of-pocket cost to the consumer? What can they expect to pay? And it's, that reflects their coinsurance, it reflects the negotiated discount, but it's price transparency in the context of this conversation is what can a consumer expect to pay. Now, this is the Healthcare Financial Management Association definition, and HFMA recently issued a report on price transparency. They convened a multi-stakeholder group to really hash out this issue, and it's healthcare financial management, so it's a lot of CFOs, hospitals, medical providers, and purchasers. CPR was a part of this group. And it was really amazing to see how much time HFMA had to just start on definitions, because every stakeholder has a different point of view and would determine price differently. And in the way HFMA determines price or defines price is that it is what the provider is expected to be paid for their services. So, just obviously wherever you sit in this system, price is going to sound different to you, or it's going to appear different to you. When I use it, I'm going to be talking more about what it means to the consumer. But recognize that price, from a provider point of view, and HFMA, which is multi-stakeholder, they agreed that the definition is what can a provider be paid. And transparency, it's not, our definitions aren't all that different. But the one thing that I don't have on here is that the other term that's frequently interchanged here is cost. And so there are costs of services that can be different than the price of the service. And so the cost of something is different to me as a consumer. In the HFMA report, the cost of providing a service from a hospital is what it means to perform the service. And so cost isn't really something we'll be talking so much about today, but I think if you're interested in this HFMA report, which provides some guidelines about some guiding principles as well as some solutions from a multi-stakeholder point of view, I think it'll be very interesting for you to see. I looked at the attendee list, and you're all probably quite informed about the need for price transparency. We might disagree on how you get there, but in terms of the need, just from a purchaser's point of view, they continue to face rising healthcare expenditures, and more of those costs are being borne by the consumer. And it's really hard as a purchaser to expect your employees to be responsible, and in terms of being, if you're a self-funded employer, to be really fiscally responsible with the dollars, their own dollars, if you can't give them information about what services are going to cost. So there's that need. The next need is that purchasers, I'm sort of flexing my muscles here, is that they really do believe that they're starting to believe that they can start to exert some real pressure here to make these changes. And it's an underused lever to really move the needle on price and quality transparency. And the other thing is that Paul mentioned is this unwarranted price variation, and it's an undercurrent you'll hear throughout this presentation, but it should not be minimized, because the price variation that occurs across markets and even within markets is remarkable, and very hard to justify, frankly, and very hard to justify a correlation with quality. So the transparency can help flatten out, or at least, I press a button, so at least it could flatten out and maybe make some of those prices seem a little more rational to what the services are themselves. And we can talk about some of those wide variations during Q&A, particularly I think one that maybe most of you know about is CalPERS and their hip and knee replacement and the wide variation before they implemented their reference pricing program. This presentation is about price transparency, but I get asked all the time, so does this mean you don't care about quality transparency? And the answer is no, of course we care about quality transparency. And it's essential. It's essential that these two get paired together. We absolutely recognize that price transparency alone will not change consumer behavior. I think the FTC conference and panel that we were on, there was lots of recognition that the making the information available isn't necessarily going to change behavior. And if you don't include quality, then you perpetuate the consumer point of view that higher prices equal higher quality. And we know that not to be true. So we definitely want to pair it with quality. The reason I think, at least from CPR's point of view, there are a lot of organizations who are in the quality transparency space. Quality transparency has been on the radar a lot longer. There's lots of debate around quality measurement and what should be publicly available. And my CPR's executive director is Suzanne Del Banco, and she's the former CEO of the Leapfrog Group. And so quality transparency, safety transparency, all of those things are incredibly important, but there's a lot of work that's being done on that, and so the purchasers are really focusing on price transparency. So let's talk about where we are today. I think this is sort of a nifty slide. I'm not going to go through all of the check marks that are listed here, but price transparency was an early initiative for Catalyst for Payment Reform and purchasers, and you have the list of purchasers in front of you, and there's a bias there. These are progressive employers who are willing to take action. Many of them have taken significant action and leaders in the country, so we recognize that they're sort of the leaders of the pack. But what's important is I wore a health plan hat for a very long time, and on the health plan side, the messages coming to you as a health plan, and then as the health plan is pushing messages out into the provider community, are very confusing. They're just everywhere, and it's hard to please everybody, and as a result, no one is pleased. And so this, at least, is an effort to send consistent messages from the purchasers to the health plans about what they want and what's important to them. And so I'm only going to talk about the first three checkpoints underneath the, where are we today. I'm going to talk about our national scorecard on payment reform and what those findings showed us about transparency. The second is I'm going to give us some sad news about the state of price transparency laws in the state. And then I'm also going to talk about the state of the art of price transparency tools. So what are we seeing in the market? So talking about this first item, one of the overarching goals that CPR had is that 20% of payments to providers and hospitals should be proven to enhance value by 2020. And when that statement was created, it sounded a little catchy. And I think most people, depending on who you ask, someone would say, well, that's incredibly under-ambitious. And others would say, we're going to pass that way before 2020, so no problem. And I think what's key here is to look at the word proven. We've got lots of payment that's flowing through value-oriented or value-based contracts. Our study showed that 11%, I shouldn't say that that's a lot, but it's under the 20% threshold. But right now we're just quantifying the methods. These aren't yet proven to provide higher value. So we're at 11% of payment to providers and hospitals that flow through some kind of value-oriented contract. We have our second annual report is coming out at the end of September, so we'll be able to see what kind of progress we've made. And we have quarterly meetings with the large national health plans, and I would say that there is lots of progress. There's lots of experimentation, lots of evaluation, and we're still in the early evaluation stages to know what's really proven to provide high value. In this same survey, the National Scorecard, we looked at other metrics that are indicators of payment reform, and since price transparency is a building block to payment reform, we surveyed around the availability of price transparency tools. And we found that this was a 2013 survey that looked at 2012 data, and 98% of the health plans that were surveyed or who answered the survey offer some kind of price transparency tool. So that's fantastic. It's at least information is available. We'll get to the variation of what's available, but at least some kind of transparency tool or cost calculator is available. The sad news here is that only 2% of the membership was using these tools. And there's a really big gap between the availability of these tools and how members are using them. And we didn't really look at why so few members are accessing these tools, but having a lot of conversations around this. I mean, it can be a variety of reasons. One, maybe it's not easily accessible on the website; it's hard to find. Two, they're not looking for a shoppable service. They're looking for services more on an urgent basis, and so they just aren't going to take the time to look. And the other is that there isn't a lot of education by the employers promoting the tool itself, and that goes with benefit design. Once the employers are really using benefit designs that are going to push employees to know what their out-of-pocket costs are going to have to be, then they'll start using the tool more. So there is really no magic solution here on these transparency tools, but that's just kind of a survey that we found. The next thing I want to talk about is, in terms of the state of where we are today, is a 2014 state report card. And I'm not really going to talk to you about the methodology we used. You can kind of see how we scored. It's all available on our website. But this is our second annual report card on state price transparency laws. And CPR partnered with the Healthcare Incentives Improvement Institute, HCI3, to review three things. We reviewed state laws, we reviewed regulations that would support those laws, and then we looked at the actual websites that were to be created by these laws and scored the state legislation, regulation, and their websites accordingly. And this is different than our first report card, and I'll explain the differences in a second here. So this is what we look like. We have a big fat F across the country in terms of how states are performing in terms of their price transparency laws. And you actually might say, well, should states have price transparency laws? I mean, is that really necessary? And it's a valid question to ask. The thing is that the stakeholders actually have within their control today to make this information available. And it's not really happening on a widespread basis. So that's why state laws are important. And it also allows the consumers to have a uniform way of getting information. Sometimes if you are just getting information through your health plan or maybe Fair Health, which is out of New York, you have a variety of services and methods and outcomes to look at, so you don't have a consistent consumer experience. The other reason for state laws is the uninsured. Right now, the uninsured, they don't have a tool that they can look at what they can expect to pay. So that's the other reason why we sort of look at price transparency laws. This differs from 2013, in case any of you are wondering. We graded on a very heavy curve, which would be nice. Speaking of the business school here, it was graded on a curve. If you had 60 points out of 100, you received an A. And the first time we did this report, we thought, well, someone should get an A. And so we did that the first year around, made people feel a little bit better about their performance. But we raised the bar this year. No grading on a curve. And as a result, you can see how the country fares, including California. So let's talk a little bit about the good news in terms of what is available today. CPR did a report called the State of the Art Report on Price Transparency Tools. Again, all of these are publicly available on our website. What we did was we looked at 8 independent vendors who are offering some type of transparency tool or solution, and 4 national health plan transparency tools. Not only did we had them fill out a survey, so it was self-reported data, but we also had demonstrations of their tool using a consistent service that you would shop, so we could see what was available. And the good news here is that we have come a long way in terms of what's available to consumers. California Healthcare Foundation, which, by the way, I forgot to thank them at the beginning since they sponsored this, so thank you, California Healthcare Foundation. In 2006, CHCF did a study on the availability of transparency tools, and it was woeful. Very little was available. It was average estimates, large ranges of prices, quality information wasn't included. There really was not much activity. It wasn't very accurate and wasn't very sophisticated. And what we took away with having done a review of these 8 vendors and 4 national health plans is that there are a lot of choices. And I use the word choice loosely, so I'll get to that and when we get to the challenge section of the conversation. But there are a lot of choices. And if you're an employer, if you're a purchaser, you have the ability to maybe select something that's very high touch. It's all through phone, it's all telephonic. You get emails personalized to you from a health coach or a vendor who is really going to give you personalized touch. And sometimes that's really important for some employers who, let's say they're in the restaurant industry and they have a lot of employees who are not at a desk, they can't do a telehealth visit or anything like that, and a phone call is just the best and fastest way that they can get information. Other tools are very self-service oriented. They are they're website based, and they will push messages out. If you've had a service and you could have seen maybe a lower cost, higher quality provider, sometimes they'll push messages out to you of what you could have saved. What's really interesting about these the tools is the sophistication and the accuracy of the estimates. Now, there's always going to be this question of, well, the estimate really can't be that accurate because the service that's actually performed could be very different than what you queried. True statement, yes, that definitely happens. But for the service that you've queried, many of these tools now are running them through a real-time claims adjudication process. And so your estimate that you will receive based on your health plan, again, we're sort of talking about the insured here, not uninsured, can be a very accurate estimate for that particular service. The other thing that we see it's a difference, it's a variation, but it's interesting. You have to sort of look at it from the purchaser point of view about how you want to, what do you want to give to the employees? And one is, do you want to show them the total cost? So now I'm talking about cost of care here. So the total cost of providing that service. And then the employee can drill down further to what their individual costs are, or the reverse. They start with what's my out-of-pocket cost, and then you can build back out into what's the employer going to pay, what's the ultimate price how the provider will be paid. So it can vary in how the views. The other thing that can really vary is some of these can be very precise to the service, to the CPT code. Many of them are using shoppable services. There's difference in how you define shoppable services. So one tool to the other is going to have a different definition of what's shoppable, but at least it's more of an episode. If you are searching for maternity care, you're likely going to get the range of services, and you're going to get the episode from the beginning to post-labor. But then you can also drill down into your very specific visits. So there's a lot of, they're quite sophisticated now. I think we're very encouraged to see that they have gotten as sophisticated they are in a relatively short amount of time. And there's nothing like some healthy competition out there to move that along. So where are we going? What's on the horizon? If one, states are doing a bad job, they're getting Fs, they obviously have a lot of room for improvement. Private tools seem like they're doing a pretty good job. Where are we headed? So we're still kind of mid-2014, and some of the things that we think still need to be examined are, what do consumers need? There's a lot of research out there about how consumers respond to data and how the data are presented, but that will be ongoing. In 2015, we anticipate more activity from CMS. There's also activity at HCCI, the Healthcare Cost Containment Institute. I think I have it written down. and then we get into in 2016 some really exciting things about transparency tools for providers, and that really isn't something that's been much of a focus, and it's really starting to emerge as something that has to take place. So I'm just going to briefly talk about, in the future, what do consumers want, what do they need? And some of these may sound intuitive to a lot of people, but when you get into the design process of these tools, sometimes it's about functionality and what can you program and things like that, and it really has to come back to the consumers, what's going to be useful. So consumers do want the episode. They do want to see what a shoppable service is. They definitely want to know about the quality of the provider, so that is still going to remain a challenge for a while. So in terms of the standardization of how are we going to really uniformly assess quality, but they want it, and they want. They're sort of insatiable when it comes to information, so they'd like a lot. The problem is we still have that 2% who are using these tools, and so there's a gap we're going to have to close. So let's give us a lot of information, and then they don't ever use it. So it is what they say they want, but their actions aren't necessarily demonstrating that right now. In terms of what they need, this first item here is, I've mentioned it before, which is you really do want to display the prices in correlation to the quality. That's definitely, otherwise they keep thinking, higher price equals higher quality. And they may not always think that for other goods and services, but when it comes to their healthcare, that's how they're thinking. The other thing is that consumers do need that sort of variability or customization to either drill down or go back out, sort of really look closely, and or give them the episode so we don't really overwhelm them. We have this perpetual problem around medical jargon. What does it mean? How do we make something relevant to a consumer? It's going to exist, and I think all of the tools that are out there really try to make this friendly, or as friendly as it can be, but this is complex stuff, and so you also don't want to be misleading. And that kind of leads into this last item, which is if you can't really use simple language, then we're moving into, consumers really do need some symbols and tools and colors. Lots are using red, yellow, green, high, medium, low, fair, unfair, things like that, average, above average, best. Those are the kinds of things that consumers need. But you can also be sitting on the other side of that and saying, like, how did I are definitely doing a dance here. So now I'm going back to this state-of-the-art report that we did. So not only did we assess their current tools, but then we looked at, well, what's still missing? So this is going forward. What do these tools still need to provide? And one major thing is the quality measurement. And not only just quality measurement, I went to this school, or I'm board certified, or I'm licensed like that, but quality measures that actually matter to a consumer. There are hundreds and maybe even thousands of quality measures out there that on an individual practice basis could be very relevant to you. Yes, you want to know about those things, but a consumer doesn't necessarily need to know that. So finding that sweet spot of quality measures that really matter to consumers. What's your safety rate? What's your readmission rate? Rate of infections? Those are the kinds of things that they care about. The other thing is that we didn't see a lot of in the current tools, so we think that future tools will probably evolve to this comparison of cost and quality. And price and quality. That consumers want to be able to see these things side by side. So then we can start to condition that, wow, I actually can have a lower cost provider and they rank very high. So having that visual is very important, but then also being able to compare provider by provider in that same view, or facility by facility in that same view, will really help. And again, this is all contingent on benefit design and driving people to shop for these services. The other thing is when you put price and quality together, you're sort of getting a value equation. But most people will tell you that value is different to each individual. So price may matter to me. How far I have to drive might matter to my mom. The quality or what their neighbor said is important to someone else. And so what we'd like to see these tools evolve to in the future is how can you customize those characteristics and those preferences, so then you can actually get an output of, based on your preferences, here are the providers and the facilities that match your needs. So that we're not there yet, but that's certainly something that we could see on the horizon. And the other thing that we definitely saw in all of these, the health plan users and the vendor users, they all will measure how many people come to their site differently. So I think if you had a Castlight or an independent vendor up here, they might say that they've got over 60% of utilization. That could be, well, it's all how you measure it. Health plans might look at it differently, which is why we only have the 2%. But all of this, in order to get to our future state, means we've got to drive consumers into action and to have them use these tools. So here are a couple of the emerging issues that I wanted to just put on the radar for everyone. Dr. Feldstein mentioned the CMS Medicare data release, and they started in 2013 with hospital data, and just released the physician level data for 2014. 2015 could be just updates to those. They haven't really previewed what they plan for 2015. And I think when either the hospital data were released or the provider, the physician level data were released, CPR got a lot of questions about, what does this mean? Is this a good signal? Is that a good thing? And I think it's charge data. And charge data, many will argue, is just not very valuable information because it's not relative to what either a consumer pays or what an insurer has negotiated or what a self-funded employer is going to pay. So people will argue that charge data aren't valuable. And I don't disagree with that, but I will say is that it's a very symbolic move for CMS to have released these data, and now you have all kinds of researchers and activity around how do you take these data and make them relevant to the consumer. So I think the last one was a gigantic spreadsheet of I don't know how many thousands of lines. Average consumer was not going to be able to wade through that. But there are people right now working on how to make it work. I'm sorry.
New York Times.
New York Times did, exactly. New York Times, I think it was the next day that it was released, or maybe the same day that it was released, they were able to, they took that spreadsheet and they made it into a searchable function, and you could put in your doctor's name and zip code, and out came their report. So things can move very quickly. HCCI, the Healthcare Cost Institute, many of you might have seen the press release a couple of weeks ago now about the three health plans who are submitting data to the Institute for the purposes of creating a large public database to release price and quality information. The three national health plans are Aetna, United, and Humana. And right now, Medicare data are not included, as I understand it. But the collection of those three plans, that data, that creates quite a database. One of the things we have with price transparency and quality transparency, even if you're a United Health Group, is sometimes your data set just might not be big enough to be able to validate the data. So it's encouraging to see an effort like this. It's incredibly ambitious, which, that's a good thing. What's not quite known are what the prices will be. Are they going to be average prices? Are they going to be a range of prices? If I'm an Aetna consumer, and I use the HCCI website, am I really just going to be, put back into the Aetna tool? It's not necessarily a bad thing. I'm just saying there's a lot of things about this exercise that we don't know what it's going to produce. But I think, it's a good signal, again, in the right direction. Hopefully more plans will participate, and hopefully, from a public resource, it becomes used. The last item here in terms of an emerging area is the West Health Policy Center, and they issued a policy paper not too long ago. And what I really wanted to highlight about this paper was the emerging issue of transparency in the hands of physicians. And they estimate that there's the saying that the most expensive instrument in a physician's office is the physician's pen. And they estimate that if a physician actually has price information at the point of care, that there can be $25 billion worth of savings in over 10 years. And I think what's more, as I think about the takeaway, certainly there's a economic takeaway, but the other takeaway is that having the physician playing a role, I'm sure many don't want to say, I'm not going to play the sort of price cop here and say what's good. They definitely want to practice medicine. But some of them are not even aware of what within their own group, within their own facility, what either how they're being paid or how things are being charged. And so if there are, this also gets into shared decision making and really advancements of shared decision making, and how can the providers play a role in the shared decision making process with the patient, and then also if there are equal treatments, and maybe having an awareness of maybe the patient has a $5,000 deductible, but it's an equal treatment. Maybe they can recommend a equally efficacious treatment, but lower out of pocket to the patient. So I think we'll see on the horizon more tools that are sort of in the palm of the physician at the point of care. So then just really going forward, a lot of this is we're going to have to be testing about these, are the tools meeting the consumer needs and demands? Are we ensuring the competition among providers? Or, if we actually get to price transparency, will we still have a competitive market? And then the last one I said is sort of taking the shared decision making to an entirely new level. So with my remaining time, I'm just going to talk a bit about what's in the way. I'm sure many of you have thoughts about what's in the way and what you think will remain in the way, so we can have a good dialogue about that during the question and answer period. But the first is market power. Dr. Feldstein mentioned this in his opening remarks, which is if you don't have enough provider competition, you have very little incentive to want to reveal your prices or quality to the general public. There are many examples of this. And it's sometimes it's baffling to me, sort of on the purchaser side of thing, that if you are the biggest, if you are the best, and you are the only, then you'd want to be able to, what's there to hide. But the market forces really dictate the opposite from what we've seen so far. The second is that there really remain some contractual barriers to transparency. Many of you might be familiar with the term a gag clause that exists between health plans and providers. There are also now sort of the new gag clause is the anti-tiering, or you can't put me in different network levels, different tiers. It's kind of an all or nothing approach. And that's kind of a tale of two stories actually on the gag clause issue. We talked to the health plans, and the health plans will say that gag clauses still exist, but there is cooperation to kind of work around so that the information can be available in their transparency tools. If you talk to the Healthcare Financial Management Association or hospital CFOs, they will say those gag clauses exist and they are alive and well and are adhered to and enforced. So I don't know the answer to this one. I don't think anyone has really investigated how pervasive these gag clauses are. What I do know is that where they exist, Northern California is one area, some areas in the Northeast as well, where they exist, they affect a large population. So it may only be a single contract or a couple of contracts, but they're usually in highly populated areas, therefore lots of consumers are affected. So that's a barrier. How do we get away from these contractual barriers? And so then we get to how do we jump over that hurdle? How do we get past it? And purchasers play a major role here. This is where there are market-based responses, and purchasers have to step up. Those that are buying the care have to step up. They have to get behind and really these are very difficult negotiations that go on between plans and facilities and providers. And so if the purchaser is not standing there and saying, we demand this information because our employees need it, because our benefit designs are based on it, if they're not doing that, then this just falls to the wayside. And so the purchasers are, we've got several examples now where purchasers are really starting to stand up and say, it's unfair to have these clauses in the contracts. So that's a market-based approach. But we always know that doesn't always work out. And so there are legislative corrections that can take place, and then regulatory enforcement that can take place to prohibit these clauses and to prohibit the sort of all or nothing contracts, meaning you have to have all of our facilities in the highest tier. Even if they aren't performing at the highest quality or aren't the most efficient. So there are some legislative remedies. The second challenge that we sort of see is the data sharing. And this really falls into the camp of, the first one was market power. The providers aren't sharing data with health plans, and therefore plans can't share data downstream. This actually is data sharing from the plan to the purchaser. And it remains a barrier that where there are health plans who don't allow purchasers to have information and to use their own claims information to give to a third-party vendor to create a transparency tool that might work for them. As 98% of health plans, I imagine my September survey will say 100% of health plans have these tools. So health plans are offering the tool, but they're not customizable necessarily, and employers, large self-funded employers, are looking for ways to find a tool that works for their benefit design and for their employee population. And in order to do that, they need their claims data. And some plans are saying that those data are proprietary and confidential and can't be shared with a third party. And the other thing is that when we talked about where are we today, those health plan tools are becoming more and more sophisticated. They're investing more and more in those tools and those proprietary tools. And so it stands to reason that they would want to protect those assets that they're developing. But why should that not stand in the way? Well, purchasers, again, are starting to stand up and really start saying in a very public way, not necessarily in a legal way yet, but in a public way, we own our data. We are self-funded employers, and we pay these bills, and we own our data. There's lots of law that supports that in terms of ERISA and being their fiduciary duties. I could go on about that. However, employers have to also walk with their feet if they aren't receiving their data. And the thing is, I should clarify, employers get their data. The thing is, they can't use it with a third party. So I want to clarify that it's not as if employers aren't getting their own data. They do receive their data in their requests, but it's the use of that data with a third party that is really and so purchasers are standing up more, saying, we actually own this data. They're starting to take a stronger stand and requiring it, and maybe walking with their feet. And we'll see if there are legal actions. But there really shouldn't be any concern around the transfer of the data. Sometimes that's used as a reason not to. So that's, you have HIPAA, you have high tech, you have ERISA, lots of protections in place that all parties have to adhere to, so somewhat of a red herring. The last thing I'll talk about is anti-competitive behavior and the challenge for this. So without, I'll skip kind of to the second bullet here, which is most people are concerned that if you reveal prices, you will providers are going to act in an anti-competitive way, potentially, and use it collectively to set their prices, and that's a possibility. The other thing is that if all prices are public, then do you dilute the health plan's ability to negotiate a discount? So it's kind of the reverse of it. And the other thing is that transparency can definitely cause confusion in the market for consumers, because your out-of-pocket costs are going to vary based on your insurance status, your benefit design, and so. But the biggest one there is, if you make these data public, will providers look at it and compare themselves and say, "Oh, I'm a low-cost provider now. I can actually raise my prices." Do all boats rise in this scenario? And do health plans sort of lose that discount negotiating leverage? Kind of overcoming that barrier, I would say, is that you have, we definitely have existing antitrust laws, anti-competition laws that should be enforced to prevent that behavior. It also takes a lot of resources to prevent that. So that's a tough one, but there are laws that should prevent that from happening. The other is that price information can be displayed to a consumer that's customizable to them, that is only available to them. So the provider shouldn't necessarily be able to see, because it's only consumer related. We all know, our neighbor might have a different health plan, and they'll give me my password, and I can get on, and I can figure out what it is. But that takes a lot of effort. And then the last thing is that the more health plans and vendors are offering these tools, and there's more demand from large employers and purchasers, the more these tools are going to get better. And so, it's almost the competition, as we've seen so far, is really moving the needle. We have some examples from New Hampshire I can talk about in Q&A in terms of, did those prices really rise once they were made available. We also could say we're in Orange County right now, where we live in California. New Hampshire isn't necessarily the example that you want to compare yourself to. But I'm going to wrap this up with California, and I'm going to be pretty quick on this. And if there are specific questions around California, I can attempt to answer them. I'm no longer in the business of tracking bills on a day-to-day basis, as I was under Nick and other places, and so I'm somewhat relieved to not have to follow these bills on a day-to-day basis. But if there's someone in the audience who has more current information than I do, they can feel free to share it during Q&A. But on the legislative side, there are 3 main bills that are moving through the legislature. All have passed their respective houses and have moved to the other side. So they weren't part of the cutoff. They are moving. And all of them, I would say, or the first 2 relate to all payer claims databases. We haven't really talked about all payer claims database, but when I speak about databases broadly, that's what I'm really referring to. AB 1558 creates, the shorthand version of this is an APCD housed at UCLA. And there are some policy ramifications about creating a public resource, and there's governance issues that I don't think have been hashed out in that bill, but nevertheless, there is an APCD bill that's moving. The second one, I have mandatory reporting to APCD. That's actually not what the bill says right now. The bill actually creates a commission to form to look at broad cost issues, but it's somewhat of, I guess those in the know up in Sacramento will say that it's somewhat of a shell bill that will, or feeder legislation that will eventually lead to potentially mandatory reporting to an all-payer claims database. And then SB 1340 is legislation that is clarifying some of the bills that passed in recent years that were to prohibit gag clauses in California. But there were some, I won't say loopholes, but there were gaps that needed to be fixed, and it seems as if stakeholders are all in agreement that those gaps need to be fixed, some of which are self-funded employer data are included now, and one of the gag clauses provisions was that it only applied to hospitals, and now it will apply broadly. Let me move to regulatory activity quickly. Commissioner Jones at the DOI received a $5.2 million grant to create an all-payer claims database. He did issue a request for information. I didn't see anyone from the DOI on the attendee list, so if I missed that, you have more information. But the DOI did issue a request for information, and they got many responses. But there is no silver bullet. No one has this information in a single repository today. And it's very hard to then kind of take what is out there today and put it into a single repository. So I think they're in the regrouping phase of what really should we do with this grant, these grant dollars. The other thing is that there's the state innovation grant. Shorthand is sort of SIM, but it's the California State Healthcare Innovation Plan. And in that grant request to the federal government is the cost and quality reporting system. And this too is an initiative around all payer claims databases. And looking at what's in the voluntary activity column right now, looking at these voluntary activities with CHIPI, which is really looking at health plan data, and then IHA, which is looking at provider data, and trying to use these resources and possibly create them into a statewide APCD. The last thing is that UCSF has been having conversations with stakeholders around price transparency and APCDs as part of a Grow Foundation, and so it's just more of a conversation that's happening. Not really sure if it will develop into an APCD, but I think what you can see from all of this is that lots of activity. APCD seems to fall in every single column, but are any of them coordinated? And they don't seem to be coordinated right now. And they're not coordinated, and so then will they really result in in something that will be of public good, or will it create more burden on those that have to submit the data? And will each of the various interests kind of keep their interests in mind only and not look at the greater resource that could be developed? So with that, I will conclude my remarks, and I'm pretty close to time. So thank you again for having me. Appreciate it. And I guess we'll move to question and answer. Yes?
One of the marketplace developments among purchasers is the move to private exchanges as part of a defined contribution approach. And if I, as an employer, pay you $6,000 to go to the exchange and purchase, it would seem that that might take some of the wind out of the sails for my having a very strong interest in price transparency. If I have a defined contribution approach, I'm going to pay you a certain amount of money, then I don't have that same incentive. Are you seeing that develop? Do you see the exchanges pursuing it with the same passion? How is that going to impact?
So on the private exchange side, I agree with you. I think it definitely could take the wind out of the sail of the purchaser role. The health plans who are offering within either a private exchange or the public exchange are still going to have the same incentive to create robust tools. I haven't really seen, well, so then there's also, I'm going to probably speak a little bit beyond my knowledge base here, but there's also a recent, I guess guidance is the best word to use, that employers can't do, the defined contribution, and it's intended to keep employer-based coverage. And so I think it's yet to be seen how many employers actually move either to the private exchange or just give their consumer or their employees dollars to move over. So I think the purchaser incentive to have a robust tool is going to stick around for a while. But on the public exchanges, they very much have built into their contracts with qualified health plans the expectation around price and quality transparency tools. They haven't used specific standards, and so each exchange might have a different standard about what should be available to consumers. But they are including it in if you're going to be a qualified health plan, particularly in California, it's the one I know best. They actually, when we did our state-of-the-art report, we had a list of specifications. Actually, back in 2012, we had a list of specifications of things that should be included in a transparency tool. And it was really intended to help employers as they search for tools. What should they be asking for? They didn't know what to ask for, so this was a list that helped them ask. What we found was that all of the vendors and the health plans are actually using this checklist against their own tool, which is a very good result. California used that checklist in their qualified health plan in order to determine the plans who could be. So I would say the exchanges, public exchanges, are using it or are seeing and will maintain a demand for transparency tools. Yes.
Hi, I'm AJ Batra, one of the pediatric cardiologists, so I'm a consumer and a provider. And by the way, great talk, excellent talk.
Thank you.
The question that we've struggled with at my end is, I heard a lot about the consumer transparency, but I think the thing we have to realize also at a provider level, the physician, we don't have much transparency either. And I've struggled with that. And we've gone to our hospitals and, the majority of the costs for the patients, consumers, end up at the hospital. And for us to cut those costs, we need to know, we need to have a better transparency as to say, okay, this is what it costs, this is less expensive or more expensive. And so if we have that transparency, we can make those changes. I was wondering if you have any ideas or suggestions as to how, that can be done as well. I mean, is it going to take, how do we have the hospitals open up to the charge master to what their, insurance contracted rates are? Is it the gag clause that's kind of prohibiting some of this stuff, and how do we, is that something, or other tools, other ideas, suggestions that you may have?
It's a really fascinating dynamic that occurs. It's definitely, maybe I'll answer the question with somewhat of an example, which is even within large integrated health systems, that information is not transparent between facility and the providers in that facility. So there are lots of barriers within systems that prevent that. I don't think the gag clause issue is really an issue. That's really a plan facility issue. It's possible that I guess providers who have contracted with facilities have that in their contract, but that's not something I've really looked into. I don't hear that. So I don't really think it's a gag clause issue. I think it's more it's more within the system about, you know, the demand for sharing information with those that are providing services, you know, at the facility. So I think some of it has to, maybe the facilities aren't feeling the demand that they don't need to provide those data to those providing the services. I'll give the example of, so at the beginning I mentioned I was doing a lot of work on bundled payment for hip and knee. And it's very fascinating to, when you break apart these individual costs that are either with the surgeon, the implant costs, the facility fees, all of those things. The surgeons are always shocked at what the facility fee is and how much of the overall payment is actually going to the facility and not to the surgeon. So what you're describing isn't, it doesn't sound like it's unique, unfortunately, but I also think unless maybe you get to start to move into bundled payments, where understanding those, we're all in this together, and if I'm all in this together, we're all going to know what each other is going to get out of it. That's one way to kind of push the envelope. And the other thing is I don't know enough, I guess, about the facility side of whether they feel there's a demand to share those costs downward. Charge masters should be available. Charge master information should be available. So that doesn't seem like it's a barrier, but so it's not a question we really examined, but I would say, given the other work I've done around bundled payment, what you're describing is not unique, but if it's a challenge, it's also a challenge within the provider community to try to solve. Purchasers aren't really in the best position to try to solve that particular problem.
I mean, I would just say that as you look at this in the future, it's important to differentiate in terms of the providers between the facilities and the physicians, because they're not necessarily the same lump, and there may be incentives for the institutions to not share that information, because even if they share it with the physician may then go and say another facility hits cheaper at the other facility, and I may go practice there because then I may get, So there are these things, and at the end of the day, there has to be transparency for everybody, and that's an open market.
Agree. Absolutely agree. Yes?
Related to his question, do you see greater transparency among ambulatory providers like an ambulatory surgery center where that highlights their competitive advantage relative to acute care hospitals?
We haven't done a sort of a direct comparison. I would say anecdotally, the answer is yes. Anecdotally, I would say that the price information that's shared with the purchasers from an ambulatory care setting is more transparent. The other thing is that more ambulatory care centers are starting to move into this bundled payment type arrangements, and so again, in that situation, you've got greater transparency around the costs. So, but could I tell you that it's really only anecdotal that they're probably more transparent? Yes.
Can you say something about reference pricing?
Sure. Do people know what reference pricing is? Okay. I'll start with what reference pricing is. So reference pricing is where basically, whether it's purchaser or plan, sets a price, a threshold for a particular service. And if you seek care from a provider that is above that reference price, then the consumer is responsible for the difference of anything above. If you seek care from a provider that is below a reference price, then there's sometimes no cost sharing, or you have your normal cost sharing. The best probably examples of reference pricing are CalPERS hip and knees, where they set a reference price for $30,000. They set that $30,000 based on looking at their historical claims data and saw the wide variation of prices going from $15,000 to $110,000, and no increase in quality between those. So they set a reference price of $30,000 and did a very aggressive campaign to educate CalPERS employees and retirees about the price and the quality of the facilities that were at or under the reference price. And they there were very big shifts in volume to those reference price facilities. Now, in this hip and knee example, it was not a bundle payment and it was just the facility. It wasn't an entire episode, but they saw major shifts in volume to reference priced facilities. And even those facilities that were above the reference price came back to CalPERS and said, we want to be at the reference price. And so they were willing to lower their price so they could get the volume that they might have had previously with retirees. The other example would be Safeway and colonoscopies. Reference pricing is usually used for commodity-based services, or what they call commodity-based services, where quality is thought not to vary. And usually on the hip and knee and colonoscopy, there were quality checks in place to make sure that the facilities that were providing the services at or below the reference price were of equal or higher quality to those that were the higher price facilities. So reference pricing is now, the administration has announced that reference pricing is a benefit design that is acceptable. There were some questions about whether that would go past the out-of-pocket or it would violate the out-of-pocket maximum from the Affordable Care Act, and they've determined that it's not a violation, and so reference pricing may be a tool that could be used more frequently by employers. I will just say on reference pricing, it's a pretty blunt instrument to send a message into the market about what, we're paying this price, we've done our analyses, we're going to send our employees to these facilities or to these providers based on that reference price. The argument against it is, well, that facility is just going to find another line item to make up the difference. Okay, so maybe they give you $30,000 on the hip and knee, fine, but I'll make it up in cardiac care, or I'll make it up in the NICU, or I'll make it up somewhere else. That's a real possibility. We don't have evidence yet of how that is happening yet, but it's a possibility that it can be that change. But it does send a very strong message into the marketplace that the variation in prices really won't be tolerated anymore, and there's a threshold for that service that you're providing, unless you can demonstrate 10 times the quality that someone else has demonstrated, which hasn't proven to be true. Colonoscopies can be 10 times, one price can be 10 times the other, but there is not 10 times difference in the quality of the service that's being provided. Does that give enough? Okay. Any questions then about it?
Time for one last question.
Uh-huh.
So I wanted to ask you about the companies that you're involved with. Are they all doing value-based kind of insurance design? And I guess I'm really asking about kind of plan design here. So
Uh-huh.
we think about the Medicare data release, and 90% of Medicare fee-for-service people don't really pay very much, and they have supplemental insurance, and so the transparency is kind of an odd thing for them.
Mhm.
What does this data mean? I can't even imagine that consumers care about that New York Times tool. I was very excited about it.
Of course, because we are all geeks, right? We like that kind of stuff.
What does that mean for them? And I guess my point is, it seems that this data and this transparency needs to be tied to something about value.
Absolutely.
And so what does it do when it's not? Or is it always being tied to something about value?
Well, I can't really speak in absolutes, but I can say in terms of our members that are, like I said at the beginning, they're more progressive. They probably are more on the bleeding edge of taking risks from a benefit design perspective. And so the answer is yes, most, if not all of them, are using some kind of benefit design to steer patients to higher value providers. And whether that benefit design is reference price, some use reference price, some use tiered networks, some are using centers of excellence and travel benefits. So it's more of a service by service basis that they're using these. But benefit design is playing, or they're moving to a full replacement HSA plan and you have a $5,000 deductible. And there are several of our member plans that have that. And so the incentive to educate their employees about these tools is very high, not just price sensitivity, but because that the employer gets they can be very risk averse. I don't want employees mad at me for doing these kinds of things. So these employers are more progressive, but it has to be paired with some other kind of incentive. And to the point over here, there has to be there could be perverse facility or provider and physician incentives, more probably on the facility side, that there are perverse facility incentives that are counteracting what seems to be pro incentives on the benefit design and transparency. So,
I'm sorry we're out of time, and thank you very much.
yes, thank you for having me.